In this video, we will take a look at the IV insertion process from start to finish. These are the learning objectives covered within this video. Once you determine the need to start an IV on your patient, unless you are in the middle of an emergency situation, make sure that you take the time to discuss the need for an IV and the insertion process with your patient. Answer any questions she may have and make sure to gain her verbal consent. To begin, don't forget to wash your hands. Gather all the supplies that you will need, including your bottle of IV fluid, IV tubing set, cannula, rubbing alcohol and cotton balls, tape, gloves, and a tourniquet. Sometimes starting IVs can be a messy process, so it is usually good to have a cloth to put underneath the insertion site, or else to make sure that you are over a surface that is going to be okay and can be easily cleaned if blood drips on it. Make sure to check your supplies as you gather them. When you select your bag of IV fluid, double-check to make sure that it is the right solution, that it isn't expired, and that there are no particles or things floating in it. Hang it from an IV pole if you have one, or from whatever is available, a hook or bent clothes hanger, etc. Keep in mind that it is recommended to maintain the height of the IV bag at least 3 feet above the insertion site, so that the fluid will flow well without blood backing up in the tubing. Next, remove the IV bottle cap. Depending on the type of administration port and if it was potentially touched in the process of removing the cap, clean the port with rubbing alcohol. Let's stop for just a moment and talk about sterile technique. IV insertion is a sterile process. You are infusing a sterile solution through sterilized tubing and a sterilized cannula placed within a vein through the use of a sterilized needle. Microbes accidentally introduced in this process may lead to a serious infection within the woman because they would be introduced directly into the woman's bloodstream. Be careful to maintain the sterility of anything that will be directly entering the woman's body, the needle and cannula, or anything that will come in contact with the fluid that will be entering her body, the administration port of the bag, the tubing spike, the threaded lock of the tubing, and the hub adapter of the IV cannula. Check your IV tubing to make sure that it is the right one, macro drip or micro drip, and that there is no break or tear in the packaging. Open the tubing and close the roller clamp. Remove the cap and insert it into the administration port of the IV bag, being careful to keep both the spike and the administration port sterile. You'll hear this referred to as spiking the bag. For example, someone may ask, "Could you spike a bag of lactated ringers for me, please?" Then squeeze the drip chamber and fill it up 1/3 to half of the way full. This helps to prevent air bubbles from being pulled into the tubing with the fluid, which is why you want to do this before you start priming the tubing. Make sure you don't fill it all the way full, or you won't be able to see the drips fall and tell what rate the fluid is flowing at. Now prime the tubing, flush it with the solution, by slowly opening the roller clamp until the fluid starts to drip at a slow to moderate rate. Continue to allow it to drip until the whole tubing set has been completely flushed with the solution. Make sure that there are no large air bubbles or sections of the tubing filled with air. If there are, then continue to flush the tubing until the air bubble is removed. Small little bubbles are not a concern. Make sure that you have tape readily available to secure the IV with after insertion. If someone else is helping you, then they can hand you the tape when you need it. If you are working alone, it is good to tear off pieces of tape and tack it to a piece of furniture near you so that you can access it easily. Apply a tourniquet 4 to 6 inches above where you want to start an IV. A tourniquet serves to help distend the veins so that you can visualize them and palpate them better. You want to tighten the tourniquet enough to cause the veins to distend, but you don't want to put it too tight or leave it on for too long and cause your patient's arm to turn blue. Keep in mind the 2-minute rule, and don't leave a tourniquet on for longer than that. There are different types of tourniquets. Some are like this that you simply clip and tighten on the patient's arm. Or there are basic latex bands that you tie. To tie a latex tourniquet, place it underneath the patient's arm. It is generally best to tie it at the underside of the arm because there are less hairs there that can get caught and pulled in the process. Stretch the band, wrap it around the arm, and tuck part of one piece underneath the other. Make sure to wrap and tuck it such that the ends are going upward away from the insertion site and not downward where they may interfere with the insertion process or break sterile technique. To release the tourniquet, unclip it in the event of using a clip tourniquet, or simply pull on the end that was tucked underneath if using a latex tourniquet. Other things that aid in vein distension include gravity. Keep the limb below the level of your patient's heart. Fist clenching. Have them clench and unclench their fist a few times. Gently tapping the skin over top of the vein. Applying a warm compress for a few minutes. Or, if you are having a really difficult time finding a vein, a blood pressure cuff can be used, rather than a tourniquet, and inflated somewhere in the 60 to 100 range, which may help to distend the veins a little more. Now select your insertion site, remembering to pick a nice straight vein with no branches or valves for the length of it where the cannula will go. If you can't find any good veins on one arm, take a look at the other arm also. Once you've selected the IV insertion site, remove the tourniquet unless you are already prepared for IV insertion. Apply your gloves and clean the insertion site that you chose. It is recommended to use rubbing alcohol or a chlorhexidine solution, and to clean inward, starting at the insertion site and working your way outward for at least 30 seconds. If the skin is dirty, clean it twice. Allow the insertion site to dry completely, and remember to not touch it or blow on it after you clean in order to maintain sterile technique. Take the cannula out of the packaging and ensure that the cannula is loosened from the back part so that you will be able to slide it off easily. It is always good to take a quick look at the cannula as well to make sure that there are no obvious defects, such as the cannula being longer than the needle. Reapply the tourniquet. Using your non-dominant hand, anchor the vein with your thumb. Anchoring the vein basically involves pulling the skin around the vein and the vein itself taut in order to keep the vein straight during the insertion process. If you don't anchor the vein, oftentimes it will roll away from the needle during the insertion process, making things more difficult. Make sure you anchor well away from the insertion site so that your needle and cannula do not bump the thumb that is anchoring the vein while you are inserting it. Hold your IV cannula firmly for insertion with the bevel side of the needle up. There are basically two different ways people hold the cannula. If your cannula has wings, you can hold it like this. It is just important to make sure that your gloves do not touch or bump the cannula in the process. Or you can hold it this way, which works regardless of if the type of cannula you use has wings or not. Whichever way you hold your cannula, make sure that you can easily see the flashback chamber as you are inserting it. Insert the needle right on top of the center of the vein you selected at a 30 to 35 degree angle, again with the bevel of the needle up. Skin is tough, so the first step is getting the needle through the skin. Sometimes going through the skin and into the vein happens simultaneously. You often feel a release both when through the skin and when into the vein. You can also feel a slight pop when entering the vein. Watch and look for blood in the flashback chamber of the IV cannula, which indicates that you are in the vein. Once you've felt the release, indicating that you are in the vein, and see blood in the flashback chamber, the tendency is to think that you've got it, and to try and advance the cannula into the vein. Oftentimes, this will result in a failed IV insertion attempt. Let me show you why. The needle sticks out several millimeters beyond the IV cannula. When the needle punctures through the wall and enters the vein, you will usually get flashback, but that doesn't mean that the cannula has entered the vein. If you try advancing the cannula before it has entered the vein, it will often just push the vein away, and you lose it. So before you get overexcited and go to advance the cannula after getting flashback, take a breath and first flatten out the angle of your cannula to one almost parallel with the skin. Then advance the needle and cannula at least several millimeters more. It is important to decrease the angle before you do this. If you maintain a 30 to 35 degree angle while advancing it, it's likely that you will puncture through the other side of the vein. I've taught this here as basically 2 steps, starting with a 30 to 35 degree angle to get the needle through the skin and into the vein, then decreasing the angle before advancing the cannula. But I want to take a moment to note that these 2 steps happen more often than not simultaneously and become one step, one smooth motion of advancing through the skin and into the vein while decreasing the angle of your needle in the process. Once you've decreased the angle of your IV cannula and advanced it a little further, then go ahead and advance the cannula all the way into the vein while maintaining the needle in the same position. Some choose to simply pull the needle back a little and then to advance both. Let's put this all together now. Here you can see the release of getting through the skin and into the vein, as well as the blood in the flashback chamber. Notice that she has decreased the angle of the needle in the process to one now almost parallel to the skin. This is the one smooth motion of getting through the skin into the vein and decreasing the angle that I was talking about. She advances the needle a little more, and then, keeping the needle in the same position or pulling it back slightly as she goes, she advances the cannula completely into the vein. It is important that you do not try to advance the cannula and then pull it back on the needle again. The catheter is flexible, so it may bend as you insert it. If you pull it back onto the needle again, you risk shearing off the tip of the cannula with the sharp point of the needle. This sheared off piece of catheter could make its way to the heart and the lungs and cause a life-threatening emergency. Sometimes as you advance the cannula, you may feel resistance and be unable to advance it further. This is likely due to a valve within the vein. Don't give up yet. Continue on with the next steps. Attach the tubing and start a moderate drip going. Sometimes the extra fluid flowing through the vein will help the valve to open enough to allow you to advance the cannula the rest of the way into the vein. You never know until you try. Once the cannula is advanced, your next step is to remove the tourniquet. Otherwise, the increased pressure within the veins is likely to cause the blood to come out of the cannula when you remove the needle, making quite a mess. After the tourniquet is removed, occlude the vein with the top of your non-dominant hand above the cannula, not on top of the cannula, as that won't work and is painful for the patient. Then, remove the needle. Sometimes, depending on how deep the vein is and how well you are able to occlude it, blood may drip out when the needle is removed until the IV tubing is attached to the cannula hub. That's okay, don't panic. This is one of the reasons it's good to wear gloves. Attach the connector of the IV tubing onto the cannula hub, making sure it is attached and screwed on well, and again, being careful to keep both the connector and the hub of the cannula sterile. You can take a moment to clean up any blood that dripped at this point, but just be careful to stabilize the cannula well so it won't accidentally fall out. Slowly turn the roller clamp of the tubing until it starts dripping at a slow rate. Take a moment to monitor the IV site with the solution running to make sure that it is dripping well and that there's no swelling of the tissues surrounding the cannula. Starting IVs is a skill, and like any skill, it can take some time to learn it well and to become comfortable with it. Even those who've started many IVs will sometimes have unsuccessful IV starts. If an IV start is unsuccessful, these are a few of the things you may see. If the cannula is not actually in the vein when you go to advance it, it may still advance into the tissues. However, when you attach the tubing and start a drip running, either the solution won't drip, or if it does, you'll immediately notice the tissues start to swell. This is referred to as an infiltration. In either event, immediately stop the drip, remove the cannula, and apply a dressing. We talked about the possibility of puncturing through both sides of a vein, which may result in blood leaking out into the surrounding tissues. Sometimes a vein may just blow as soon as you puncture it if the vein is fragile or if the pressure within it is too great. This causes blood to flow out of the puncture into the surrounding tissues. You may hear this referred to as blowing it, and in either of these events, even before you attach the tubing and start the solution dripping, the leaking blood will cause the tissues to start to swell. If you notice this, immediately release the tourniquet, remove the cannula, and apply a dressing with pressure for a few minutes to help minimize the trauma to the surrounding tissues. Just to note, sometimes during insertion, a vein will collapse, for example, in a patient who has lost a lot of blood. In this case, you may not see flashback, but that doesn't mean you are not in the vein. If it feels like you are in the vein, or you think that there is a chance that you might be, don't give up. The only way to know if you are in the vein or not is to continue on with the steps. Advance the cannula, release the tourniquet, attach the tubing, and start it dripping. At this point, you can monitor closely to observe if the fluids drip and there is no swelling, indicating that you are in, or if it doesn't drip, or does drip but swells, indicating an infiltration. Once you have an IV in place with the fluid running well through it, the next step is to tape it up. There are multiple ways to tape an IV. The first step is taping and anchoring the hub, and there are 3 basic ways this can be done. The first 2 work regardless of whether the cannula hub you use has wings or not. Some use what's called a C method, the chevron method. This involves placing one strip of tape, sticky side up, right underneath the hub. Then, one side of the tape is crossed over the hub at an angle in the opposite direction, and then the other side. Another option is what some refer to as the U method. One strip of tape is placed sticky side up underneath the hub. Then, one side is folded up parallel to the IV cannula, followed by the other side. Lastly, there is the H method, which is used for a winged cannula. One strip of tape is placed sticky side down over each wing, and then one is placed directly over the hub. If you noticed, all these methods to anchor the hub are done such that the insertion site is visible. Ideally, a transparent dressing is then placed over top so that the insertion site is protected and can be viewed at all times. This way, signs of an infection or problem could be noticed right away. If you do not have access to or use transparent dressings for your IV sites, then an additional wide piece of tape should be placed over top of the insertion site to protect it and keep it clean. After the insertion site is well taped, form a loop of the tubing so that it is directed away from the hand, and use a few extra pieces of tape to secure the tubing to the arm. The loop and extra tape help serve to protect the IV site so that any tug or pull on the tubing will not be directly on the insertion site itself. After an IV is inserted, make sure to chart what vein the IV cannula was inserted into, what IV solution was hung, and what drip rate the fluid was set to. I want to briefly talk about adding medications to an IV bag and changing out IV bags. To add a medication to your IV bag, for example Pitocin, draw up the medication in a syringe. Maintain sterile technique by cleaning the medication port of the IV bag with rubbing alcohol, and inject the medication into the bag, being careful to not poke a hole in the bag in the process. Gently shake the bag a little to mix the medication all throughout the solution. Add a label to the IV bag that has the date, the time the medication was added, what medication was added, and the dosage. If the bag of fluid is not full, you may want to write how full it was at the time you added the medication. To change out the IV bag, for example, if you have a patient with a severe postpartum hemorrhage who requires a second liter of IV fluid, close the roller clamp fully. Ideally, this should be done before the bag is completely empty and air has started to fill the tubing, in which case you would also have to disconnect the tubing from the cannula hub and re-flush it again to remove the air. Double-check your new IV bag again to make sure it's the right solution and that it's not expired. Hang up the new bag and remove the administration port cover. If needed, clean the port with rubbing alcohol and allow it to dry. Remove the spike from the empty bag, being careful to keep it sterile, and insert it into the administration port of the new bag. Slowly reopen the roller clamp and set it to the desired rate. Make sure to chart that a new bag of IV solution was hung. According to the Center for Disease Control and Prevention, IV cannulas can stay in place for 72 to 96 hours before you would need to consider discontinuing it and starting a new one at a new site. As a midwife, you are probably not going to encounter patients that need an IV for longer than a few hours or a day, so the only reason you might need to remove it and start a new one is in the event of complications or it becoming dislodged. To remove an IV, put on gloves. Make sure the roller clamp of the tubing has been closed. Gently remove the tape or dressings that are covering the IV cannula and tubing, starting with the pieces on top. Gently place a piece of sterile gauze or a cotton ball over top of the insertion site, but do not press on it yet. It is painful for the patient if you apply pressure on top of the cannula. Grasp the hub of the cannula and pull it straight out in one smooth motion, applying firm pressure to the gauze or cotton ball over top of the insertion site as soon as the cannula is fully removed. Hold pressure on the site for a few minutes. Ask the woman to hold pressure for a few minutes, or wrap a wide piece of tape firmly across and around the woman's arm or hand to form a pressure dressing. Always make sure you check your cannula once you remove it to ensure that it is intact without any splits or missing pieces. Dispose of the cannula, tubing, and IV fluid bag as appropriate for the place you are working at. It is a good habit to write a note in your patient's chart with the time the IV was removed, whether or not the cannula was intact at removal, as well as a total record of how much IV fluid was given and any other details that may be important to note.